Maybe we can go ahead with your
Okay.
second talk.
My second talk, what I wanted to do is the task at hand was how to treat patients with high fibrosis. So I'm going to give you an overview, and hopefully this will tie in with the following presentations to make sure that we cover this. Before I start, I always make this presentation with the caveat that I cannot give you every single regimen, every single iteration, every single modification you need to make, and I don't think you should memorize those. That's not really the strategy. We have several sites that will give you up-to-date, monitored information that will help you to do that. Your time is better spent treating the patients and addressing the preparation of the patient to treatment and addressing all the policy issues of how to get the drug to patients than to worry about which specific regimen you use. But we'll cover them, and we'll touch on specifics. I also asked Jimena to send you all via email a one-page summary of what my recommendations are that are going to cover pretty much every patient you have to that's not co-infected with HIV, and hopefully that will help you. So I want to touch very briefly on interpretation for the diagnosis. I mean, I think that this is probably bringing coals to Newcastle. I don't really need to delve on this. It's been covered already. I usually give this as kind of my introduction. I think it's worthwhile to talk about glossaries in this new era of these medications that are so impactful. So let's talk about when we talk about resistant substitutions, and this is really defined as a phenotypical change that conveys a higher EC50 than the wild type to any specific strain. So think about it like you would think about any other bug that you're treating, any bacterium or fungus that could be resistant to treatment. These are phenotypical changes. The interesting thing is there is data to show that all these modifications existed because the virus, Hep C virus, has its evolutionary strategy is to have infidelity in the copies so that in replicating at a very rapid pace, it generates variants that may not be infective, that may not be very fit, but that may contain a variant that makes them survive onset of attacks by the immune system. And for some reason, I don't know, I mean, we could talk ad nauseum about why this is, but some of these things pre-existed before we invented the direct antivirals, before people were exposed to them. Now, viral fitness is a related topic that refers to the ability of a virus, variant or otherwise, to live in the host. And some of these mutational changes may give the virus fitness to resist the impact of the antiviral, yet it may not be a very fit virus that can be wiped out by immunological impact on the hepatocytes that are infected. Because given enough time, the immune system will clear Hep C, and that's what happens in our sustained virological responders. However, you may have a combination of mutations, and this can happen because the virus, again, replicates very rapidly, that allows a virus in the population that the patient has to be both resistant and fit. And that's actually the case most likely in resistant variants against the NS5A mutation, but that could, the NS5A drugs, and that could actually be something that we will see in the future. Barrier to resistance is something that you also hear, and that really refers to the specific agent and its inherent biochemical ability to actually overcome viral mutations that will reach resistance to that particular agent. And so you just need to know inherently each one of them has a different barrier. In our case, for example, the protease inhibitors and the NS5 agents are very potent drugs, but they have a relatively low barrier to resistance. The newer ones are getting better with that respect, but sofosbuvir, fortunately, is one of those agents that is very potent and has a very high threshold to resistance. When you test for these mutations, you need to understand that again, if you look at this sketch, which I really like from Gastroenterology in 2012, this is a sketch of the population of virions in one individual. And as you can see, there are subpopulations that are there at much lesser numbers, and our assays may not be able to detect every single variant. If you go into next generation sequencing or high high accuracy genotyping, you would be able to detect the minor strains. But clinically, you only have to demonstrate that you have a resistant strain that represents about 15% of the population in that individual for it to be clinically meaningful. So that means that population sequencing, which is widely available, is what you see, is actually going to be clinically important. You don't need to drill in to see if they have very small numbers of copies of a particular mutant, which you will wipe out because they may not be fit. So the 15% threshold is what's being bandied about as the number you need to know. All right, so now let's go to the specific treatment options. And this is focusing on US predominantly available regimens. I know that some of them will come to you very soon, and if I'm spending too much time on one that you don't have available or you don't care to hear about because you'll never see it, let me know. These are treatment recommendations. I actually am one of the co-chairs of the AASLD IDSA guidance panel, and we really went to great extent to make very clear that we think this is an infectious disorder and everybody who has hepatitis C should be treated. Realistically, we know that these drugs are expensive and that we perhaps ought to give priority to some individuals. We probably overemphasized that when we initially launched, and that was a negative to the patient population that needed treatment because many patients were denied treatment under a false pretense, and that was never the intent. So what I usually recommend is that we obtain a viral genotype titers, we do fibrosis assessment. The staging of disease is very important, and I keep on saying that we really need to know who is cirrhotic or at risk for developing cirrhosis before we actually get to treating them and understanding that, because those patients, as I'll touch on later, are the ones that I recommend that we hold on to because they will feed our liver transplant programs and they will need our attention because there will be problems with cirrhosis that will arise. Now, this topic came up earlier in the meeting, and that's what do we do with RAS analysis? I think that patients who have been exposed to direct antiviral agents before, in whom you're entertaining treatment, particularly if they're genotype 1A or genotype 3, should be tested. I think it's irresponsible to spare them a $200 test that will spare them a $50,000 treatment that may not be effective. So you need to really engineer the therapy and really be, but it really is a limited number of patients. A naive to therapy patient, with the exception of a patient who has cirrhosis and has genotype 3, perhaps that group is the only naive to therapy group that deserves assessment of the presence of RASes. Because otherwise, you really don't need to worry. The vast majority of the rescue therapies will actually overcome any existence of RASes. We talked about this. Please be sure to know about hepatitis B, particularly if they have surface antigen presentation. That's very important to know about that. It is a great opportunity to co-diagnose HIV because we know that it responds just as well as the non-co-infected, but if we don't know they have it, we miss an opportunity to treat the HIV as well. Then I always make a point of discussing the non-infected sexual partner testing and precautions to be taken. There's no data to suggest that barrier methods help, but I think there's nothing that tells you that they don't help. And I think that the risk is low enough, but they need to understand it, and we probably need to test sexual partners to be sure. And have to remind, depending on the population you see, that they can be reinfected. So those of you who are treating patients who may potentially still be using injectable drugs, please be sure they understand that treatment does not preclude reinfection. And don't forget that if you have a cirrhotic patient, really you should continue to follow them in hepatology. I don't release those patients to the primary care doctors because they will not know what to do. Now, the recommendations change rapidly. Please be very mindful of drug-drug interactions. That has been already hammered several times over. I won't spend a lot of time. But rather than looking for the stage of disease, I really look for poor compliance patterns. And those are the patients that I don't treat. If I think my patient's not really serious about getting treated, doesn't matter how advanced the disease is, I wait until they're really committed. And that's the person that I say, you come back and see me later. But most of the patients, I fight very hard to get them treated if they have coverage. I'm gonna skip through this. And you guys have all seen this. I don't know that anybody's mentioned the fact that you can get this on your phone. So this is very worthwhile to have on your phone because you can check on decisions on the fly. I don't think that the recommendations for the actual treatment course should be done on the phone, but I think to check for drug-drug interactions, it's free and it's very accurate. And I think for most drugs, actually, it's very helpful. I do know that there are some that aren't there, but I think it's important to keep that in mind. This is another one that I would keep in my favorites. I have a conflict of interest in telling you it's good, but I do think it's good because it's a consortium of two societies, and we've worked really hard to make sure they're accurate. We view them, review them, retest them, play around with them, and we've hopefully made it accessible so that you have access to the most effective therapy, not how much it costs, not whether you have it in your country, but if you wanted to treat any one patient, these drugs exist, and those can be prescribed. This is the summary of the drugs that we have available. No new drugs are coming. So this is what we're going to have. And I know even here, I know I have acinoprovir there. We don't have it available in the US. I tend to avoid that drug because I think there were some signals in the test that really led them not to pursue it in the United States, particularly because it doesn't work very well against 1A, but it's one drug that I don't really have a lot of love for. And I will mention the ones that I think are most important for you to remember in the next few slides. But this is another take-home message. I've mentioned how we can now treat up to 95, 98% of our patients. If you continue to accept the very slow trickle of patients that come to your practice, refer to you, and we have 95% SVR, you'll see that the cure goes from 10% to a little bit less than 20%. So it doesn't matter what we do until we impact the number of patients that are diagnosed, who recognize they have a disease, and who pursue therapy by whatever means. And that really leads to a change in the prevalence of the disease. Very important to recognize that. So in cirrhosis, I was asked to comment on what I would do with a patient who had stable cirrhosis. Portal hypertension is understood to perhaps decrease exposure to meds. Many patients with cirrhosis have been experienced patients, and so they may have potential resistance in their midst. And some drug classes, particularly the protease inhibitors, are less safe in the cirrhotic population. So I think that those things need to be taken into consideration when you decide what you're going to use or for how long you treat. Staging and HCC diagnosis is extremely important. So you need to know before you start therapy whether you have cirrhosis or whether you're intermediate or whether the patient has an HCC, because the decisions as to how you treat and when really are impacted by that. Data suggests that patients with pre-cirrhosis and early cirrhosis respond very well to DAA therapies. I don't give you the citations. There's multiple papers. So cirrhosis doesn't make the treatment any worse. Drug classes may require longer therapy in patients who have hepatitis C-related cirrhosis. And ribavirin continues to be a very solid adjuvant in the treatment of patients with advanced disease. I think that a lot of my colleagues disagree with me, but ribavirin is very well tolerated without interferon. Even though you may see a little bit of anemia, they will do very, very well. So I'm going to focus again on optimal regimens. And again, please don't take notes. I've given you this in a handout, and I'm going to touch only on the major genotypes. But since we're talking about cirrhotics, I don't know, is Sofel not available to you yet? Or is it available now? The Sofel-Patosvir, it is. Great regimen for cirrhosis at 12 weeks. Usually, and I'm not going to go into the decompensated disease, but that's where ribavirin may actually come into play. The GP regimen is very good for cirrhotics for 12 weeks, but for most patients, an 8-week regimen is actually quite reasonable. The Harvoni regimen, as you'll see here, you can use it for 12 weeks. I usually tend to add ribavirin to those patients who have cirrhosis just to be sure that I clear them. I've had a lot of patients who I see treated for 12 weeks and they come back with a relapse. They're very happy that their virus responded and they relapsed. Elbasvir, grasoprevir is economical, but with genotype 1A, you've got to be sure you look for the resistant strains. So that to me adds a little bit more complication to the regimen, and I'm not the biggest fan of this regimen. I think genotype 2 is not a particularly prevalent virus in Mexico, and correct me if I'm wrong. But you will see it, and I think that sofdacladazvir is a very good regimen. You just need to recognize that if cirrhosis is present, you need to treat for longer, and I tend to add ribavirin to that group. That's not it's not a recommendation that's coming from the ASLD necessarily, but I think that in that patient population, I've had some failures in cirrhosis with genotype 2. But GP is a very easy to use regimen for 12 weeks in this patient population, as well as soft-vel, and you don't necessarily have to use ribavirin in that patient population. For genotype 3, again, soft-vel is usually my go-to in this, but the GP is also very good, and it only is an 8-week therapy. The only reason I don't really touch on this is because with patients that have more advanced cirrhosis, it's a regimen that has a protease inhibitor, and I worry a little bit about what that can be. So that's why the shorter regimen is not listed number 1 in here. And then softacitabine, again, it's very important that ribavirin be considered, and I would treat for 24 weeks in that regimen in patients who have cirrhosis. All right, and I'm going to fly through genotype 4, 5, and 6 because the recommendations first are not really that important to your patient population, and they're not that common. So the rescue therapies, I know that you're waiting with beta breath to get soft-vel-vox. It's a very good regimen. I usually don't recommend it for the compensated liver disease or for renal failure because we have the GP for renal failure, and because the VOX is a protease inhibitor and in decompensated disease, I think there's some risk and there's no need to take it. So what do we do once we achieve sustained virological response, which is one of the questions that I think sort of nigs at us at all levels. So sustained virological response is durable unless you're treating somebody who's at risk for reacquiring the disease, particularly people who do IV drugs, or something that hasn't been mentioned, this epidemic of men who have sex with men, HIV infected or not, they get infected very readily in large metropolitan centers all over the world. So this is a group that we need to pay close attention to, whether they're HIV infected or not. And those patients I would keep in the practice to be sure that you don't underlook the possibility of reinfection or prevent it. Risk reduction strategies are really important to enforce in that situation. And then decisions need to be made according to the stage of your patients. Any patient who doesn't have NASH, who looks well, whose enzymes are normal, and have a fibrosis level of 0 to 1, you can dismiss to the care of a primary care clinician. Sometimes these patients want to be seen once or twice, and I usually entertain checking their virus at 24 months after they're done, but beyond that, I don't think it's necessary unless they have risk factors. The F2 patients, I think we have some concerns about whether they're really at significant risk, and if they have any other coexistent issues like obesity or diabetes, those patients may warrant to remain under our care. But patients who have F3 to F4 management, like anybody who has advanced disease, who needs to be seen frequently, who needs to be screened for hepatocellular carcinoma and for the complications of portal hypertension. So the patient who's cirrhotic, I do surveillance. I use an alternation of MR with ultrasound depending on body habitus. I look at alpha-fetoprotein. I see them every 6 months, and I monitor them for portal hypertension. I'm transitioning to using the guidelines that guide you based on platelet counts and the presence of an advanced transient elastography measure. And then I think that you shouldn't continue to check the HCV RNA. That's costly, and if the patient is not at risk, after 12 months, these patients are clear. I don't think they're going to be presenting Hep C unless they reinfect themselves. I want to leave you with this again, very important. Please look at this, and we promise to keep it updated, and if new things happen, we will inform you through there as well. I want to leave you my email. If you have any questions or concerns, please don't hesitate to reach out to me. Thank you very much for your attention.
Encendemos las luces, por favor. ¿Preguntas? Any questions?
Hugo, excellent talk. How frequently do you see your patients when they obtain the sustained viral response, and meaning of us non-cirrhotic and a compensated cirrhotic?
For the compensated cirrhotic, we have generally what we do in our clinic, because the vast majority of our patients are being treated for 12 weeks or 8 weeks. By the time they get their meds in the US, they usually get them shipped to their house. They start therapy. We like to see the baseline HCV RNA. We like to see whether in the middle of the treatment they're progressing. Many patients don't show up for that lab, but we want to know end of treatment where they are. and we see them at 12 weeks after therapy for sure. After they cleared and we confirmed sustained virological response, if they're cirrhotic, they know that they are going to continue to see me, and they come to our clinic. We have, there's 8 of us hepatologists, plus we have an advanced practitioner. We usually follow these patients on our own, but we know from this patient population, we get 1 or 2 cases that progress on to the need for liver transplantation, regardless of whether they're Hep C, SVR or not. So I think we see this as a seedbed for a liver transplant program, and we follow them, as I mentioned to you, every 6 months. Some of us have discussed really what do we do as far as checking for fibrosis. As a part of our practice, we're doing fibrosis check with a transient elastography, or if we happen to be doing MR elastography, have more data on that patient, that means we can use either one because we have them available to us. Since I'm using that for screening, that's what I like to do. Did that answer your question? Or? Yes.
Thank you. We usually do the 12-week afterwards and 24 weeks afterwards. Sometimes the patient feels like nervous and asks us to have another.
No se oye, Linda, creo que está apagado.
So what I heard was that your patients don't want to do the 12-week?
No. The other way around. I mean, the patient is pretty happy to have the 12-week and the 24-week, but sometimes afterwards, the patient is still quite nervous, and
Yes.
maybe I am too. So we perform another one maybe 6 months later. My question is, when do you stop totally? No more PCRs forever. If you ever.
Our group, we've decided that at 12 weeks, if we've had a sustained virological response, I do think that each patient comes with their own burden, and I think there are patients out there who, unfortunately, can go to the lab and order the test, and they pay for it. I don't necessarily recommend it, but some arrive at my annual visit or every 6 months with the labs already done, and they did it. I didn't order it necessarily because there's a state law in Arizona, for example, that you can just go to the lab and get whatever test you want if you pay for it. So
When we started with Pegasus, we had a protocol that they would follow for 5 years. And after 5 years, they had their scan. Obviously, if they are cirrhotics, this has to be every 6 months and so on. But the PCR, 5 years later, whether they develop hepatocellular carcinoma or not, do you think it's wise? Because we don't have epidemiological data in Mexico. So maybe if in that interest, we could do...
I hear you loud and clear. I understand where you're coming from, and you know what I did instead of putting in a blanket, relatively expensive test where I know that the likelihood of positivity is low, is I participated in the registry tests that I think Gilead and AbbVie both had long-term follow-up for these patients in their regimens. And so I've been participating on those and giving them data. So hopefully the FDA will force them to publish that information and get a better sense. But so far, what I've seen from following those patients very closely, none of them revert, and many of them were cirrhotic patients, people who were rescued from the transplant list. So I think I can sleep easily having known that the patient has gone to 12 months post end of treatment and not testing once again, unless they're at risk, unless they're out there injecting or doing something else. But I don't know, Ray, I don't know what you do in Stanford. I mean, I think that's something that I don't know that we can justify more testing.
Exactly the same. 12 months, no more.
No more. I don't think that, I think that what I tell you is that every patient going to accept that? The answer is no. I mean, we can tell the patient, but the patients are so anxious sometimes that they will continue.
Yeah, I know. Right now, we are participating in two follow-up post-marketing, but that's just for adverse events. This is with Sovaldi, any combination of Sovaldi.
The ones in the U.S. have looked particularly at cirrhotic patients, and they're looking for our assessments of the status of the cirrhosis. So we're looking at Child-Pugh score, how are they doing, biological testing, and viral status, and all of that. And they take all the information we get, so that some of them, those patients have been followed and have had fibroscans. The fibroscans stabilize. I don't know that they all reverse, but I'm hoping that at some point they'll have
Maybe the first fibroscan or elastography that you do afterwards, it improves, but not because of fibrosis improvement, but by inflammation improvement. Yes. So I think the good ones are maybe after a year or so to really see how much they improve.
We're
Do you
not
agree?
protocolizing FibroScan, and I didn't mention that. We're thinking about doing it every 2 to 3 years because it incurs a cost. It's not like, like the Canadian system where, you have the machine and you put it and that's it. I mean, we actually have to bill it. So it is expensive to do the FibroScan. We charge $400. So it's, it's not a cheap test. But I do think it's much better than biopsying the patient and maybe save the biopsy for a few years down the road.
I'll tell you, it's cheaper than in Mexico in some places.
True.
Sí.
Well, about viral load, there is a published paper where viral load was continued up to 3 years and it remains negative. But for some protocols like the AbbVie, the AbbVie pharmaceutical company, we are in a long-term study, and the follow-up will be up to 5 years. So it was a request from the FDA. Just check up to 5 years, annual visit, and we'll see what happens. But it's already published 3 years, negative.
Yes.
Okay, about coming back to my first question, non-cirrhotic. So you mentioned compensated cirrhotics, you see them every 6 months.
Yes.
Would you say that non-cirrhotics F2, F3 annually, visits after SBR?
I think that's the area where I think things are a little fuzzy. I think F0, F1s, I dismiss them from the practice. They don't have to come back. And generally, those patients have normal numbers. But if there's people out there, and you probably have a few of those that have NASH or who have other comorbidities, those patients should remain in your hands because they may be subjects for other studies down the road, and they may have risk. F3, usually when I have the FibroScan where I'm at 11 or at 10, that patient probably should stay with us because I don't know why that is, particularly if they have high fat, if the CAP level is high. I keep that patient because I think that patient is not the F0, F1 who clear virus and has a normal appearing liver all the way through. So I handle them a little differently. The problem we have is capacity. So, the capacity to continue to follow us.
Ray?
I forgot to add this in my talk, but I think this is a helpful mental exercise to think about this population with advanced fibrosis and cirrhosis. So the natural history, as Hugo illustrated, is that once you have patients like that, they continue to progress and they develop hepatic decompensation and other complications and die, right? So they disappear. But now with DAAs, we can rescue them very, very effectively. Almost all of them we can cure, but their fibrosis doesn't disappear overnight. So if you look at the whole population itself, advanced fibrosis before DAA, they die off. Now they survive, and they don't develop decompensation. But what happens is they remain at HCC risk. So if you follow the population, you can model this out and say you will see even more HCCs after DAA because these patients don't die off. Whereas in the past, they're not there any longer. So I think it's even more important for us to remember and educate primary care doctors whenever you have patients who look like advanced fibrosis, err on following them and protecting them from HCC.
And Ray, you trigger something that I've tried to develop in the Mayo Clinic has a number of primary care clinics available to us. The partnership that I think would really lead us to improve the treatment of patients who are undiagnosed and those who are treated is to link up when you get referred a patient. You call that primary care doc and say, hey, listen, I'm going to treat your patient, and the fibrosis level was, say, 3 to 4 based on FibroScan. That individual needs to be seen every 6 months. We need to look at liver injury numbers, biomarkers for tumors, whatever we have now or what may come in the future, and also have some imaging done. Why don't you see him every year, as you normally would? You get an ultrasound, alpha-fetoprotein labs, and then I will take care of getting the MRI, which I can handle in my institution. I can interpret it, and I will keep you in touch. And by the way, if you have another Hep C patient, just send them to me. So you don't have to take care of that. You do that. And so when you work in that level of partnership, the patient's being seen by you once a year, so it doesn't increase your capacity concerns as much as having to see them twice a year. and you're talking to a primary care doctor who now knows you have a partner in hepatology that's going to help you. I mean, these are the kind of strategies that improve the quality of life for our primary care docs, and they will probably lead to more diagnoses of hepatitis C than what we see by just telling them, oh, test everybody, or test this, or
That was exactly what I was just about to say. Just to complement with a few extra words, I think that we are living in a transitional season in which we are moving from all liver biopsies and more precise diagnosis to knowing that liver biopsy offers sampling error and that some of the tests that we have, ancillary studies that we have, are not so tremendously precise. So I think that in our advantage, cirrhosis is not a disease of one day. So just as Hugo just said, you just follow the patient, and you establish a strong communication with your referring doctor, to your primary care physician, and he will follow, you will follow, and at the end, the chances that you have to miss cirrhosis and perhaps later on HCC, it's rather small, if we do the right things.
Okay, I guess with this, we can wrap up this part of the course. I think it was fantastic, both of your talks. I appreciate them very much. Thank you very much, Hugo. Les pido entonces que